I welcome you all on behalf of Maha IP and Women's Committee Maha IP today for this program of Doctors Awareness Session of Autism Session. I welcome all the dignitaries of this program, President, Secretary Maha IP, all the executive members, guests, and the guest of honor and the guest speaker. Myself, Dr. Sonali Shirbhate, moderator for this session. As you all know, Maha IP is celebrating this April as Autism Awareness Week from 2nd April to 8th April. Theme of this Autism Week is Inclusion in Workplace. We had celebrated 2nd April as MChat show where our expert doctor guided us about the interpretation of MChat form. Diagnosis of ASD is challenging and difficult. No specific tests are available. Only history of development of child is important. So Maha IP and Women's Committee Maha IP had brought this session for doctors where our eminent guest of honor and our guest faculty will be guiding us for the autism session. So I welcome President Dr. Hemant Gangulia sir. I welcome Secretary Dr. Amol Pawar sir. I welcome our guest of honor Dr. Leena Srivastava madam. I welcome our guest faculty Dr. Samir Dalwai sir, and I welcome our Women's Committee Chairperson, Dr. Renu Boralkan madam. I welcome all the executive members and the audience. Now I would like to request our President for his presidential address. Over to you, Gangulia sir.
Thank you, madam. Good afternoon and namaste to the respected faculty, Dr. Samir Dalwai bhai, as well as guest of honor, Dr. Leena Srivastava, my Secretary General, Dr. Amol Pawar, all office bearers of Maha IP, Maha Women Committee, Chairperson, Co-Chairperson, Dr. Renu Madam, Dr. Sonali Madam, as well as Dr. Neha Madam. And at the outset, I would like to congratulate Maha IP Women Committee to carry out such wonderful Autism Week in this month of April, which is known as April month of Autism month. We already have planned to release of 2 flyers and 4 sessions. Already we had done 1 session on MChat and this 4 session to follow. In our practice, we find difficult to identify, and it's our job as a pediatrician to pick up them early and refer at the right time to the right person so as to have the impact on the treatment of that. And we have none other than the excellent faculty, Dr. Samir Bhai sir, here to the session. All the best wishes to this program, and I'm sure by the end of the program, we all will be little bit enlightened and will be ready for our OPD practice. Thank you, madam, very much.
Thank you, Gangulia sir. Now I would like to request our gorgeous guest of honor, Dr. Leena Srivastava ma'am. What not to say about her? In short, I would like to say that she is developmental pediatrician and neurodevelopment consultant at Pune since 23 years. She is head at the Child Development and Guidance Center at Bharati Vidyapit Medical College, Pune. She is visiting neurodevelopmental consultant at various hospitals of Pune. She is a coordinator for IEP developmental behavior pediatrician. She was secretary at IEP chapter of Neurodevelopment Pediatrics in 1819, and she is joint national coordinator for IEP TOT for NDDS and PSPP module. She is also member of task force for IEP guidance on ADHD, autism, learning disability, etc. So I welcome madam and would like to request you for your welcome address. Pallavi, please unmute madam. Pallavi madam, please unmute Leena madam.
Yes, ma'am. She is already co-host.
Unmute.
Yes, ma'am. Done.
Yeah. Good afternoon, everybody. It is indeed a privilege to be part of this massive movement of autism awareness that Maha IP has taken up, and I think it is the need of the hour. Post-pandemic, I think we're all struggling to keep pace with the amount of children we're all seeing, and I think it's a wonderful initiative at such a large scale to create awareness between pediatricians, parents, teachers, and everywhere. So I thank the whole team under the dynamic leadership of Dr. Gangolia, who I think leads by example. He's there all the time trying to get things together with the excellent support of Dr. Amol Pawar, and of course, the effervescent and enthusiastic women's team headed by Dr. Renu and Dr. Sonali. It is a privilege. And as Dr. Gangolia sir rightly said, that I think we really need to identify the different presentations. And I think that's exactly what Dr. Samir Dalwai, our great speaker, which all of us love to hear, would probably make clearer to all of us in today's session. Thank you so much, and privileged to be with all of you today.
Thank you, dear madam. Now let us know some much more about our faculty speaker, Dr. Samir Dalwai sir. There is much more to say, but I had tried to cut short Sir's CV. Sir is a developmental behavioral pediatrician at Mumbai. Sir is recipient of Government of India Rajiv Gandhi Manav Seva Award for his services to child health in 2012. Sir is founder, director, and consultant at New Horizons Child Developmental Center, Mumbai. Sir is attached to Nanavati Hospital, Mumbai. Sir is national treasurer for IIP and past president IIP Mumbai. Sir is past chairperson of Neurodevelopmental Pediatric IIP chapter. Sir is editor-in-chief of IIP Handbook of Developmental Behavioral Pediatrics. Sir is member of Government of Maharashtra COVID Task Force for Pediatric. And sir has many publications. And sir is a member of expert panel of Maharashtra State Commission on Child Protection Act as well as for malnutrition. So I welcome sir for his presentation and session for case-based approach for children in autism. Welcome, sir.
नमस्कार, धन्यवाद डॉक्टर सोनाली जी. सर्वप्रथम respected Dr. Hemant Bhai Gangolia ji, our loved president of Maharashtra IIP, my dear brother Dr. Amol Pawar, secretary of Maharashtra IIP, my very dear friend Dr. Leena Srivastava, with many years of work with her, Dr. Jayashree madam, Jayashree Shivankar madam, who has taken so much effort for this coordination, executive board member from Mumbai, Dr. Samir Sadavarte ji, Dr. Neha Singh, who I see posting 24 hours round the clock, something or the other about Maharashtra IIP, and I was wondering who this person is. Dr. Kashmiri Vadbade, who I am a part of today's session. All the respected executive board members, office bearers from Maharashtra IIP, from Central IIP, Dr. Renu Golwalkar, who I thought was in Maharashtra but currently seems to be in the Caribbean. So very nice to see all of you here, and thanks again to Maharashtra IIP dynamic team led by Dr. Hemant Bhai Gangolia and Amol ji, who are doing such wonderful job. Thanks Dr. Sonali for the excellent introduction, and pleasure to always be here with Leena Srivastava. I would like to start. I think there is some echo going on, so we'll wait for a minute. So, yeah, can you see my presentation?
Yes, sir. Yes, sir.
Again, for the honor and congratulations and thanks for taking up the cause of awareness of autism in such an excellent manner all across Maharashtra. आणि आपल्याला सध्या definitely an increased awareness from parents बघायला मिळतोय. MAIP has been working on this for the last so many years. They're getting some good awards at the national level also. As a treasurer, I'm always happy to see Maharashtra winning the award. And all these activities put together make Maharashtra IIP one of the best in the country. Today, when we were discussing about what exactly to take for pediatricians, I thought a case-based approach, case-based learning, where we see the spectrum of clinical presentations, is more important than a theoretical presentation. आता इथून उठून तुम्ही ओपीडी मध्ये गेलात किंवा कदाचित अजून ओपीडी मध्येच बसला असाल, नेक्स्ट बाळ जे येईल त्याच्यावर कसं काम करायचं किंवा तिकडे कसा विचार करायचा हे जास्त गरजेचं आहे. ऑटिझमची थिअरी ऐकून सर्वांना झोप येते. तर आपण त्या अनुषंगाने केसेस आपण बघताना आमच्या सेंटरचं एक न्यूरोलॉजिस्ट चाइल्ड डेव्हलपमेंट wherever where I have learned whatever I know. We have the entire team of people working along with the developmental pediatricians, but at the top is the child. And every child comes with a little different presentation, different story. And we have to modify our learning and our work for the child according to the child's presentation and needs, and not according to the other part that we may have learned. And following this technique, we've even been able to take our work online and helping parents all across the country and world. When we look at the data, one very important thing that I would like to tell all my younger colleagues is आपण क्लिनिकल काम करत असतो, आपण डेटाकडे लक्ष देत नाही आणि त्यासाठी एवढा मोठा डेटा, एवढा जो आपला संदर्भ असतो आणि एवढा आपला एक्सपिरियन्स असते की सर्व जनरली इज नॉट able to be of use to others. Since 2003, we started a center, but 2009, along with TISS, Tata Institute, we did a research project for 4 years, and that helped us start this habit. And now we keep the data regularly, and the data for 2009 to 2019, 11-year-old data, when we analyzed, it was 6,900 plus children. And this, as you can see, almost 3 to 4 times more number of boys or males seek help at the center as compared to girl child. But see the increase in the numbers in the last 5, 6, 7 years. And there is a virtual pandemic of autism across the globe now. And these are some of the numbers reflecting that. The other part is why today's program is so important, because look at what was the data at New Horizons in 2013 to 16. The average age of presentation or diagnosis of the child was above 6 years. Fortunately, now with greater awareness, and like Iman Bhai said, we have to recognize the child and refer him early. Once we have started doing that, this has definitely come down to 3 to 4 years. I'm sure Lina would agree. So I'm going to show some 7 or 8 cases where they present to us in the OPD and we don't know, or we need to know what to do. A 1-year-old male child is brought to you for your opinion. Parents do not think anything is wrong, but they came since they have an older 4-year-old child with autism. No evaluations or interventions done, but somebody told them the child has autism. They do not have any further details, but they came to you for this 1-year-old child to know everything is normal. What will you do? I hope this is like a clinical scenario which all of us face in our OPD. So I'd like to throw it open for everybody's comments. What will you do? Yes, please unmute yourself and answer.
His history of development and all things we will ask.
Excellent. Very good. Anything else?
Any
So-
sibling, his sibling affected with any disorder.
So the elder sibling is 4-year-old.
Elder sibling is affected. So anything same pattern, or are you observing anything same pattern?
Excellent, excellent. And that is exactly what the message from case number 1 is, what to do always. In every child who comes to you, check all developmental history and milestones. Like Sonali ji has said so correctly, there's no reason to think that this child may not have an SMA or may not have any other motor disorder or a CP. So you have to be blind. 1-year-old child came to you, don't get carried away. Very often आपल्याला autism नाव ऐकून बाबा ह्याला पण काहीतरी असू शकतं, काहीतरी भयानक होईल, आपण कशाला बघावं, याला पाठवून द्या डेव्हलपमेंट पिडियाट्रिशियन कडे, असं नको. आपण पिडियाट्रिशियननेच पाहिलं पाहिजे. आणि आजचं आपण डिस्कशन तेच आहे. तेव्हा ऑल डेव्हलपमेंटल माइलस्टोन्स टू चेक whether there is a global developmental delay also is possible. But what we must always do, डोकं लावायची गरज नाही, करायलाच पाहिजे. चेक फॉर विजन अँड हिअरिंग. आणि त्यासाठी फक्त टॉर्च शाईन करून किंवा खुळखुळ वाजवून चेक करायचं नाही. डॉक्युमेंटेड पेपरवर रायटिंग मध्ये पाहिजे. बऱ्याचदा आपण कुठेतरी पाठवतो, तिकडनं असं ऐकू येतं की टेस्ट नॉर्मल आहे. त्यांना सांगा मला ऐकायचं नाही, मला वाचायचं आहे की हिअरिंग मुलाची नॉर्मल आहे, लेखी स्वरूपात द्यावं, असं इन्सिस्ट करावं आणि ते रिपोर्ट आपल्या फाईलला लावावे की त्याचं विजन अँड हिअरिंग नॉर्मल आहे. गोईंग अहेड, सेकंड केस. आता आपण त्याच मुलाची एक गोष्ट बघूया. आता ते 1.5 वर्षाचं मूल झालेलं आहे.
Sir, Samir bhai sir, what specifically should write for hearing and which test for hearing, which test for vision?
व्हेरी गुड क्वेश्चन. विजन साठी आपल्याला पीडियाट्रिक ऑफ्थॅल्मॉलॉजिस्टला रिफर करायचं असेल, पीडियाट्रिक ऑफ्थॅल्मॉलॉजिस्ट नसेल तर जनरल ऑफ्थॅल्मॉलॉजिस्ट विथ गुड इंटरेस्ट इन पीडियाट्रिक्स. That is the point. 1-year-old child for hearing, only one test, Bera. You have to get a Bera done. थोडं एक्सपेन्सिव्ह असतं. मुलाला थोडंसं सेडेशनचं प्रिस्क्रिप्शन मात्र तुमच्या पॅडवर येऊ दे, कारण हे बाळ तुमचं आहे. ऑडिओलॉजिस्टचं किंवा आमचं नव्हे, तुमच्याकडेच राहिलं पाहिजे. तुम्ही पेडिक्लोरिल वगैरे जे असेल ते लिहून द्यायचं. So that is the point. Also, Hemant Bhai mentioned a very important point. Elder child, already Shulali also said, all child with autism. So we know that there is a 10 to 20% chance that this child also is likely to have autism. पण ते अद्याप एका वर्षाला बाकी सोडून तेच करायचं असं नाही. इतर व्हॉट टू ऑलवेज डू इज टू ऑलवेज चेक एव्हरी चाइल्ड फॉर ऑल डेव्हलपमेंटल माइलस्टोन्स, विजन अँड हिअरिंग. सेकंड चाइल्ड, 18 month old मेल चाइल्ड कम्स टू यू. जास्त काही बोलत नाही, जास्त बहुत ज्यादा नहीं बात करता है, बहुत कम कभी कभी बात करता है. डू नॉट थिंक एनीथिंग इज रॉन्ग, क्योंकि दे से दैट चाइल्ड यूजेस साइन्स फॉर कम्युनिकेशन. ही इशारे सर्व करतो, पॉइंटिंग करतो, हातवारे करतो, जेवायसाठी असं दाखवायचं, पिण्यासाठी असं करतो, पिण्या म्हणजे पाणी पिण्यासाठी, असं इतर काही नाही, असं करतो वगैरे वगैरे. तर त्यांना वाटतं मुलं बरं आहे, पण ते कोणतरी आंटी म्हणाली की एकदा डॉक्टरना दाखवून घ्या, डॉक्टर गांगुलीला भेटा, ते काय म्हणतात बघा. So what will you do for this child? बोला.
एकतर पहिले डेव्हलपमेंटल माइलस्टोनचं विचारलंच पाहिजे, ते तर आहे. शिवाय न खुणवता ते काही वस्तू आणून देतात का ऐकतात, ते न खुणवता कम्युनिकेशन होतं का ते विचारलं पाहिजे असं मला वाटतं.
Excellent, excellent. Anything else?
We can also go for M chart.
Excellent.
Yes.
That's another option. So now let's go ahead. What will you do? What to never ever miss? In this case, what you can see is that the child is using signs for communication. म्हणजे हातवारे, इशारे, डोळ्याने, आय कॉन्टॅक्ट, पॉइंटिंग, हे सर्व परफेक्ट आहे. म्हणजे बेसिकली त्याचा नॉन व्हर्बल कम्युनिकेशन परफेक्ट आहे, पण तो ऐकलेलं काही फॉलो करत नाहीये आणि स्वतः बोलत नाहीये. असं काही जरी असेल तर 18 months मध्ये नेव्हर मिस हिअरिंग इम्पेअरमेंट आणि त्याचं हिअरिंग असेसमेंट करणं गरजेचं आहे. त्याचबरोबर आपण पुढे येऊया. थर्ड केस, 2-year-old मेल चाइल्ड इज ब्रॉट टू यू. अगेन डॉक्टर बरोबर काही बोलत नाही, हो जास्त काही बोलत नाही, बडबडत असतो काहीतरी. There are no repetitive behaviors. Parents do not think anything is wrong, but the daycare auntie insisted की daycare मध्ये ठेवलं की जरा एकदा डॉक्टर अमोलला दाखवून घ्या, सर्व नॉर्मल आहे ना बघा. What will you do now? बोला बोला.
Look for meaningful speech. Words, whatever there are they meaningful words? Then also, is there something like even need-based? Does he express his needs or show something and then has joint attention? Again, finally, hearing test is a must.
Absolutely right. Absolutely right. So here, if you see, just check whether the child has a normal receptive speech or expressive speech. He does not have. Check for non-verbal, and hence you have to go for a clinical approach, like doctor was saying. First and first, again for this child, always what to never miss is always do a hearing evaluation, do a general systemic examination, check for all milestones, and in a clinical evaluation, systemic examination, neurological examination, look for skin markers, neurocutaneous markers, microcephaly, macrocephaly, etc. And then again, this is the concept of doing a screening test called MCHAT, which you have to do anytime the child is beyond 16 months of age to 30-32 months of age. So in this approach, what are the red flags for clinical thing? No big smiles or joyful expressions. By 6 months of age, the child does not look at the mother. There are no smiles, no joyful expression, no response when child's name is called. By 10 months, mother is calling, कधी कधी बाळ फिरतं आणि बघतं, कधी कधी बघतच नाही. Does not gesture, म्हणजे हातवारे वापरत नाही, पॉइंटिंग करत नाही, बाय बाय वेव करत नाही 12 महिन्यापर्यंत, आणि 16 महिन्यापर्यंत does not say single meaningful words. And I'm very happy this is the concept we had brought about almost 8-9 years back at New Horizons Child Development Center, that don't ask for history of words, ask for history of meaningful words. So these are important red flags you have to keep in mind. I will tell you something else which is interesting, and that is a sign for autism called Shah Rukh Khan sign. Can somebody tell me what is Shah Rukh Khan sign? Wow. Renu Boralkar has shown us Shah Rukh Khan sign. So this is Shah Rukh Khan sign, which we call when the father or the mother stretches out the arms like this, like Shah Rukh Khan does. Kajol does not come running to his arms. So the child does not notice that and does not keep coming to him. So the child does not reciprocate this non-verbal loving gesture. So if Shah Rukh Khan sign is positive, then we can understand that this child has some problem. So Hemant bhai, हे मी मुद्दाम नाव अशासाठी दिलंय की शाहरुख खान पर्यंत गोष्ट पोहोचली तर आपल्या महापेडिकॉन मध्ये चीफ गेस्ट म्हणून त्याला आपण येऊन ह्या क्लिनिकल सायन्सचं इनॉग्रेशन त्याच्या हस्ते करूया, म्हणजे आपलं पण काम होईल. अशी IIP ची कामं करत राहायची असतात. इतरांनी ऐका, तसं IIP कामं करत राहायची असतात. हॅज एनी लॉस ऑफ लँग्वेज और सोशल स्किल्स ॲट एनी एज, म्हणजे त्याचं मिनिंगफुल वर्ड्स त्याचे होते, पण आता काही मिनिंगफुली बोलत नाही, फक्त बॅबलिंग करतोय. म्हणून हिस्ट्री विचारताना फक्त वर्ड्सची नव्हे तर मिनिंगफुल वर्ड्सची विचारली पाहिजे. डज नॉट प्ले विथ टॉयज अप्रोप्रिएटली, म्हणजे गाडीला गाडीसारखं न वापरताना फक्त त्या गाडीच्या चाकांशी किंवा दाराशी ओपन आणि शट करत असणे किंवा रोलिंग करत असणे. फिक्स पॅटर्न्स ऑफ इंटरेस्ट ऑर ऍक्टिव्हिटीज, म्हणजे पूर्ण गाडीत इंटरेस्ट न घेताना फक्त गाडीच्या चाकांकडेच लक्ष देणं, त्याला आपण लिमिटेड, रेस्ट्रिक्टेड किंवा फिक्स्ड इंटरेस्ट असं म्हणतो. लाईन्स थिंग्स ऑफ, प्रत्येक गोष्ट एका प्रत्येक लाईन मध्ये लाईन अप करायची, एका विशिष्ट प्रकारे त्या वस्तूबरोबर खेळायचं. has odd movement patterns or repetitive behaviors like hand flapping, spinning, finger flicking, वगैरे वगैरे. These are all the red flags. Very important, all of you go to your mobile phones and type mchat online. mchat online. तुमच्या फोनावर आता करा. तुम्हाला एक क्वेश्चनेअर येईल, एक एक प्रश्न विचारला जाईल, 20 प्रश्न येतील. प्रश्न तुम्ही मराठीत रूपांतर करून किंवा मराठीत पण कदाचित आता मिळत असेल, पालकांना विचारा, त्यांचं जे उत्तर असेल त्याप्रमाणे स्कोर टाका. 20 प्रश्न विचारून झाले की ऑटोमॅटिकली तुम्हाला स्कोर येतो. हा फ्रीली अवेलेबल आहे. एमचॅट फ्री आहे. तुम्ही पेशंटकडून चार्ज मात्र करू शकता, पण चार्ज केलं तरी चालेल, पण करायला मात्र विसरू नका, कारण इट इज व्हेरी व्हेरी इम्पॉर्टंट. इफ द स्कोर इज लेस देन 2, लो रिस्क आहे, पण 3च्या वर जर स्कोर असेल तर बेसिकली आपल्याला लक्षात आलं पाहिजे की याला डिटेल्ड असेसमेंट पाहिजे आणि इतरांकडे किंवा डेव्हलपमेंटल पीडियाट्रिशियनकडे रिफर करणं अनिवार्य आहे. At New Horizons, we have defined another term which is called a social communication sequence. तर आता ASD, MChat वगैरे झालं, but what is more important is chat with the parents. Don't just do an MChat. Instead of that, chat with the parent. Is the child's verbal communication normal? तो व्यवस्थित एज प्रमाणे मिनिंगफुल वर्ड्स बोलतो का, तो कमांड फॉलो करतो का, नसेल तर हातवारे कळतात का, पॉइंटिंग कळतं का, स्वतः पॉइंटिंग करून दाखवतो का, करत नसेल तर किमान त्याचं इंटरॅक्शन, आम्ही जे न्यूरोसायन्सला आमची थिअरी जी आहे की मनुष्य मग्नता कमी आहे, वस्तू मग्नता जास्त आहे, किंवा मनुष्य मग्नता कमी आहे का, जर ह्या तिन्ही गोष्टी म्हणजे नसल्या, रादर चाइल्ड इज नॉट वर्बल करेक्टली, चाइल्ड डज नॉट हॅव नॉन वर्बल कम्युनिकेशन आयदर और डज नॉट हॅव इंटरॅक्शन आयदर, दिस इज अ सोशल कम्युनिकेशन डिसऑर्डर. एक गंमत आहे इंग्रजीत, नॉन वर्बल म्हणजे नॉट वर्बल नाही. नीट आहे का? नॉन वर्बल असणे म्हणजे नॉट वर्बल असं नाही. वर्बल असणे म्हणजे मूल बोलू शकतो, नॉन वर्बल म्हणजे बोलत नाही पण इशारे हातवारे करतो आणि कळतात. तेव्हा नॉन वर्बल असणं पण गरजेचं आहे. आपण नॉन वर्बल म्हणजे नॉट वर्बल फक्त असं नाही. नॉन वर्बल म्हणजे वर्बल नाही पण नॉन वर्बल आहे, म्हणजे इशारे आणि हातवारे आहेत हे कळणं गरजेचं आहे. कारण जर ते देखील नसेल, वर्बल जरी नसेल आणि इंटरॅक्शन जरी नसेल, तर डायग्नोसिस इज सोशल कम्युनिकेशन डिसऑर्डर. दिस वी मस्ट कीप इन माइंड. आता 3 वर्षाचं बाळ आहे.
Samir sir, one just one question, one query. It is mentioned that doesn't utter a single word up to age of 16 months. Such children, does every child requires this screening? Is requires screening because आपलं म्हटलं जातं, लोक ते त्यांचे घरवाले म्हणणार नाही नाही आमचा मोठा मुलगा होता नाही ना 3 वर्षांनी सर्व शब्द बोलायला लागला, तो 2 वर्षांनी काहीच बोलत नव्हता पण 3 वर्षांनी बोलायला लागला. अजून आपल्याकडे जनरल पिडियाट्रिशियन की आमच्या पिडियाट्रिशियन मध्ये आज टेंडन्सी आहे की जर रिलेटिव्ह बोलले, पॅरेंट्स बोलले की मोठा उशिरा बोलत आहे मग आम्ही ओव्हरलुक. इज दॅट राईट और इज दॅट रॉंग अँड वेदर वी शुड द स्क्रीनिंग एट द राईट टाइम इवन इफ देयर इज नो सिंगल वर्ड?
व्हेरी व्हेरी गुड क्वेश्चन. मूल 16 मंथ्स पर्यंत मिनिंगफुल बोलत असेल तरी सुद्धा एमचॅट करा. एमचॅट सर्वांचंच केलं पाहिजे. इट इज अ युनिव्हर्सल स्क्रीनिंग for every child comes to your clinic. This is very important to understand. But especially if you are suspecting, then you have to do it. आता ते पालकांना कसं सांगायचं हा वेगळा मुद्दा, पण करणं हे अनिवार्य आहे. बरं, व्हेरी ऑफन द चाइल्ड विल हॅव रेपिटेटिव्ह एकोलेलिया. तो शब्द बायहार्ट करून पोपटासारखे रिपीट करतोय. तेव्हा आपल्याला मिनिंगफुल आहे किंवा नाही याच्या वादात आई वडिलांची जायची अजिबात गरज नाही. आपण 16 महिन्याचा आहे, 18 महिन्याचा आहे आणि आपल्याला वाटतंय की वर्बल मध्ये काही गडबड आहे, इंटरॅक्शन मध्ये गडबड आहे, आय कॉन्टॅक्ट गडबड आहे, शाहरुख खान साईन पॉझिटिव्ह आहे, लक्ष देत नाहीये, नो बिग स्माइल्स, डू अ एमचॅट फॉर शुअर. So that is my answer, that we have to do an MChat. कारण काहीतरी अधोरेखित स्वरूपात आपल्याला एखादा काहीतरी टेस्ट करणं, it's better and more confident for us की it's not my opinion, it is a MChat screening tool which is showing that your child is at high risk. म्हणजे आपल्यावर न घेता ना आपण ते टेस्ट सांगू शकतो. बघा तुम्ही रिपोर्ट आणला, तुमचं हिमोग्लोबिन कमी दाखवते, मी तुमचं हिमोग्लोबिन 7 आहे असं म्हणत नाहीये, रिपोर्ट सांगते तुमचं हिमोग्लोबिन 7 आहे, तेव्हा आपल्याला अमुक करावं लागेल. दॅट वे. ओके.
Sir, should we also go for screen time history?
So for every child, you have to ask for screen time history and decrease it and tell them to stop it totally for every child. That's what we have been doing at New Horizons again. At least 12, 13 years, we have old records where when we didn't have a software or a laptop, we used to handwrite the notes, no TV or screen time. This is extremely useful because this is one of the most important interventions for children. But screen time does not cause autism. It worsens autism. We'll come to that later. Okay. Anything else?
No, sir. Thank you, sir.
3-year-old male child is brought to you for hyperactivity. वर्गात बसत नाही, आपल्या जागेवर बसत नाही, खूप चंचलता आहे, मस्ती करतो, तोडफोड करतो. बोलतो की कधी कधी जॅक एंड जिल बोलत असतो, व्हील्स ऑन द बस गो राउंड राउंड राउंड, चांगल्या ऍक्सेंट मध्ये, अमेरिकन ऍक्सेंट मध्ये बोलतात आमची मुलं. ही लाइक्स टू फ्लॅप हिज हँड्स व्हेन एक्साइटेड और एंग्री. काही चुकी वाईट नाही, पण ते नर्सरी टीचर का मग कोणास ठाऊक का म्हणते की ते एकदा तुम्ही डॉक्टर लीना श्रीवास्तवांना दाखवून घ्या म्हणून का असं करतायत ते. तुमच्याकडे आले की त्याच्यानंतर तुम्ही काय करणार? 4-year-old child.
MChat for sure.
Okay, very good.
And of course, again, hearing and vision also.
Excellent. Yes, go
Because
ahead.
most important is probably this rhymes and all what he says is wrote what he's saying. It is not meaningful in any sense.
Absolutely right. So again, the same approach we have to do. We have to follow.
And probably also check for the associated comorbidity of ADHD.
So let's not go there so far. Let's go step by step again. Is this child's verbal development age appropriate? No. If no, is his non-verbal communication age appropriate? No. Is his interaction age appropriate? No. Then we know that the diagnosis is social communication disorder. But there is another problem here. This child has hand flapping, repeated actions, keeps repeating words. So there is history of repetitive behaviors and restricted behaviors. So social communication.
Call it echolalia.
Yes, so that is echolalia, social communication disorders plus repetitive restricted behaviors. The diagnosis is autism spectrum disorder. Is this clear? It's very important not to get confused with ADHD or anything else at this point of time, and to understand that if the child's verbal, non-verbal interaction all is bad, plus he has repetitive behavior, restricted behaviors, be clear to give at least mention the possibility of autism. People are afraid, so they will use अरे बाबा एकदम रावण नको, रावणाचा लहान भाऊ सांगू आपण. So everybody says no ADHD वाटतंय कारण आपल्याला भीती वाटत ते सांगायला. Don't do that. This is straightforward. You should say that I suspect child has autism spectrum disorder. I'll just play some videos for you. So this child has poor, meaningless, or actually meaningless eye contact, no proper verbal or non-verbal. And these are the repeated actions that you are seeing. And she's rocking movement now. So all these are signs of ASD, not just SCD. So you can see the 6-year-old daughter on the left, typically repetitive behaviors, poor eye contact, poor interaction, poor non-verbal, poor verbal. But look at normal. Look at the 10-month-old child. Gradually you see, he will start interacting with me. See this Shah Rukh Khan sign, is trying to hug me. Can you see that? Once he establishes a rapport, he will want to hug you. He will put his arms right. See this, see this, see this. So all these things are normal development. But what the girl on the left is doing, totally absence of interaction, repeated movements, this is autism. A 4-year-old girl child is brought to you. Now, girl child, we are saying, parents say she says some words, but not quite a lot. शी इज नॉट एट ऑल हायपर ऍक्टिव्ह. इनफॅक्ट आपल्या खुर्चीत शांत बसलेली असते, कोपऱ्यात बसते, कोणाला डिस्टर्ब करत नाही, कोणाशी बोलत नाही, कोणाशी इंटरॅक्ट करत नाही. हिस्ट्री विचारल्यावर कळतं की प्रिव्हियसली रेपिटेटिव्ह बिहेवियर्स होते, पण डॉक्टर आता काही असं नाही आहे. इनफॅक्ट डॉक्टर माय चाइल्ड इज सो गुड की ती अल्फाबेट्स लिहू शकते, शब्द कॉपी करू शकते, नंबर्स कॉपी करू शकते. तसं असं आम्हाला काही वाईट रॉंग काही वाटत नाही, पण कुठेतरी काहीतरी गडबड होऊ नये म्हणून आम्ही तुमच्याकडे आलो. व्हॉट विल यू डू? What will we do? So again, let's follow the same algorithm, the same approach. This is a child who has poor verbal as per age, poor non-verbal as per age, poor interaction. She had some past history of repetitive behaviors. She is very good at copying alphabets, that is also repetitive behaviors. Copying words and numbers is also repetitive behavior. Copying the alphabets from the blackboard or arranging the alphabets, this is repetitive behavior, because a child who can't speak, how do you expect her to be able to understand reading and writing? So this, in the clinical setting, I will call this ASD with good academics in inverted commas. I'm saying it sarcastically, please don't take it seriously. This is not good academics. This is just pattern copying or echolalia or pattern copying for writing. Please understand this. So they may say good academics, but it is not. It is ASD with good copying ability or repetitive patterns. So don't miss this child. 10-year-old boy, see what happens if you miss this child. Now 10-year-old boy diagnosed with autism at 3 years. Somebody had diagnosed him, they had gone to America, and then look at the amount of work they have done. He has received intense speech therapy. Intense म्हणजे काय? आठवड्यातून 6 वेळा, बरं का? त्याच्यात काय होतंय ते काय इंटेन्स नाही. 6 वेळा करा, 7 वेळा करा, आठवड्याला 10 दिवस असेल तर 10 वेळा करा. केलं, काही फायदा झाला नाही, पोपटपंची वाढली, नंतर स्टॉप केलं. त्याच्यानंतर ऑक्युपेशनल थेरपी कोणीतरी सांगितलं, मग काहीतरी सेन्सरी वेन्सरी 3 महिने ते करत होते, त्याच्यातून काही सुधारणा नाही, मग ते स्टॉप केलं. मग रेमिडियल म्हणाले कोणीतरी, स्पेशल एज्युकेटर करा, शाळेत शॅडो टीचर करा, ते केलं, त्याचं काही हे नाही, कॉपी करायला जास्त लागलं, समजत काहीच नव्हतं. बऱ्याच वेळा हे काउन्सिलर ते काउन्सिलर, इकडचे काउन्सिलर तिकडचे काउन्सिलर, मग कोणी ABA सांगितलं, कोणी आर्ट बेस्ड थेरपी सांगितलं, आता म्युझिक थेरपी चालू आहे. कोणीतरी फोन करून त्यांना ऑनलाईन इंटरनेटवर त्यांनी सर्च केला ऑटिझम म्हणून, तर ऑटोमॅटिकली त्यांना गुगल ऍड्स पाठवते, कलर थेरपी, मॅजिक थेरपी, स्टेम सेल थेरपी, म्हणजे वाटेल ती थेरपी चालते. आता अगेन पेरेंट्स फील ही इज गुड अकॅडमिकली, का? कारण तो कॉपी चांगलं करतो, रिडिंग रायटिंग करतो म्हणे. बट पेरेंट्स फील्स ही लॅक सोशल मॅनर्स अँड हॅज सम डिफाईन्ड बिहेवियर्स. म्हणजे काकांकडे जाता येत नाही, मामांकडे जाऊ शकत नाही, अभ्यास करतो पण कोणाकडे कसं वागायचं कळत नाही. व्हॉट विल यू डू? So again, after the clinical evaluation, you will be sure that he has autism. But what confuses you is, अरे च्या एवढी थेरपी करून का उपयोग झाला नाही? कारण प्रत्येक थेरपी गरज नसताना आणि ज्या चुकीच्या गोष्टी कुठल्याही वेळी काही केल्याने असं होतं. तेव्हा थेरपी दिली, चाइल्ड विथ ऑटिझम, OT दिली, झालं, हे साफ चुकीचं आहे. चाइल्ड विथ स्पीच डिसऑर्डर, ASD, स्पीच थेरपी रिफर केली, बस, अजून काही करायची गरज नाही. दिस इज द रिझल्ट. सो आर यू गिव्हिंग द राईट ऍडवाइस? Have you formulated the right diagnosis? And where does the child stand today? आज त्याचं सोशल इंटरॅक्शन किती आहे, त्याचं नॉन व्हर्बल किती आहे, व्हर्बल किती आहे, अकॅडमिक स्किल कुठे आहे, आपण बघितलंय का? आपण म्हणतो मल्टीडिसिप्लिनरी म्हणजे काय? एक थेरपिस्ट वाटेल ते करतो, दुसरा थेरपिस्ट त्यांचं करतो, दोघांना काहीच माहित नाही, डॉक्टरना माहित नाही दोघे काय करतायत. दॅट इज नॉट इंटरडिसिप्लिनरी. हा, मल्टीडिसिप्लिनरी असेल पण त्याचा काहीच उपयोग नाही. आणि शेवटी क्वालिटी ऑफ इंटरव्हेन्शन. क्वालिटी ऑफ इंटरव्हेन्शन म्हणजे थेरपी देताना एअर कंडिशन रूम मध्ये देतोय की नाही हा मुद्दा नाही, 1:1 देतोय की नाही हा मुद्दा नाही. इंटरव्हेन्शन दिल्यानंतर उपयोग काय होतोय, फायदा किती होतोय, त्याला क्वालिटी ऑफ इंटरव्हेन्शन म्हटलं पाहिजे. आणि ते करण्यासाठी मुलाला तुम्ही तुमच्याकडे फॉलोअपवर ठेवला पाहिजे की 1 महिना झाला, जा इथे अमुक अमुक ठिकाणी हे करा, पण मला येऊन दाखवा इम्प्रुव्हमेंट होते की नाही. नाही तर असं होतं. 15-year-old बॉय डायग्नोज बाय सम एज ऑटिझम, कोणी म्हणते ADHD आहे, कोणी म्हणते इंटेलेक्च्युअल डिसेबिलिटी आहे, कोणी म्हणतो ऑटिझम आहे. हे रोजच्या केसेस आहेत. पुअर स्पीच, हायपर ऍक्टिव्ह, अग्रेसिव्ह, लिटिल डिस्मॉर्फिक फीचर्स, डज नॉट फॉलो पेरेंट्स अँड टीचर्स कमांड्स. आता शाळेत अगोदर रिडिंग रायटिंग म्हणजे कॉपी करत होता, आता ते करत नाही, आता भांडत असतो, व्हेरी अँशियस, कोणी काही बोललं तर लगेच आरडाओरडा करायला लागतो. ही कॅनॉट बी टेकन टू सोशल गॅदरिंग्स. दिवाळीला दसऱ्याला कोणाच्या घरी जाऊ शकत नाही, काकांच्याकडे लग्नाला जाऊ शकत नाही, काहीच करू शकत नाही. आता त्याला डॉक्टरांकडे दिलेलं, त्यांनी कोणी मेथिलफेनिडेट कधी दिलं, ते थांबवलं, कधी क्लोरिडीन दिलं, आणि थेरपीची काय गरज आहे, तुम्ही फक्त रेस्पिरेटोन घ्या, असे सर्व ऍडवाइसेस घेत घेत 15 वर्ष झाली. व्हॉट विल यू डू? सेम थिंग, यू टू डू द क्लिनिकल इव्हॅल्युएशन. पण ह्या मुलाची गत बघा. This is I call adolescent ASD with multiple diagnoses, multiple concerns, multiple interventions. But what is sure is he was managed perhaps poorly. कारण आपण क्लिनिकल अप्रोचने मॅनेजमेंट केली नाही, फक्त रेफरन्सेस करत राहिलो. आणि वर्स्ट प्रॉब्लेम ह्या मुलांचा होतो ऍडॉलसन्स मध्ये. आणि तो ह्यासाठी की मुलं पोपट्यासारखी बोलू लागतात थेरपीने, रेमेडियल करत करत ABCD 1 2 3 4 कॉपी करू लागतात. त्याच्यात सहज 8-10 वर्ष निघून जातात. मात्र पौगंड व्यवस्थेत आल्यानंतर हा खरा प्रॉब्लेम सुरू होतो, कारण सोशल बिहेवियरचा प्रॉब्लेम होतो. आता एज्युकेशन झेपत नाही, कारण कळत काहीच नव्हतं, कॉपी किती करणार. आता एखाद वेळी मेडिकेशन द्यायची जास्त गरज असते, कारण आता कोमॉर्बिडिटीज पुढे यायला लागतात. हायपर ऍक्टिव्हिटी, इम्पल्सिव्हिटी, एन्झायटी, डिप्रेशन, ओके, ऑब्सेसिव्ह बिहेवियर. आणि त्यासाठी व्हॉट वी आर वरीड अबाउट इज द फ्युचर. नाउ फायनली आय विल कम टू द लास्ट केस. अगेन गोइंग बॅक, 2.5-year-old child, but female child is brought to you for not speaking many words. Parents do think, yes, kaitari gadbad challeli hai, because she was doing well in the first few months. She had started recognizing parents and family. She had meaningful words. She was showing interest in pointing out and sharing things. Around her first birthday, parents noticed she started losing interest in them. She stopped saying anything. She was rather lost, looking at her own hands and moving them in a particular manner. Wringing hand movements आपण म्हणतो तसे, फक्त हातांकडेच बघत राहायची. What will you do? Leena Srivastava has written a whole chapter on this in the new book that we have brought out. But what do you think is wrong?
Regression is there.
Sorry?
Is she regressing in her milestones?
Absolutely. This is true regression, because the child had meaningful words, she had meaningful eye contact, she was doing everything else age appropriately, and then she lost it. So this is true regression. पण रेणू, हे सांगण्याचं तात्पर्य 8 केसेस पैकी एक रिग्रेशनची दाखवली मी. म्हणजे 33% रिग्रेशन जे चाललंय खोटे ऑटिझम आहे, 33% रिग्रेसिव्ह ऑटिझम. दिस इज पुअर हिस्ट्री टेकिंग. कारण वर्ड आणि मिनिंगफुल वर्डचा अर्थ फरक कळला पाहिजे. She had meaningful word and she has lost it. So this is true regression. Female child, 2.5 years old. Of course, we all know that the diagnosis is Rett syndrome or MECP2 mutation. So this is how you will analyze these cases. For examination, for every child, look at whether they have microcephaly or macrocephaly. Look at whether they have any spinal deformities, kyphosis, scoliosis. Look at the skin neurocutaneous markers, Ashleigh macule, tuberosclerosis. All these other things are very important. And very important, look for dysmorphology. The 7th child which I showed you turned out to be a fragile X syndrome. He had been missed. कारण का? शाळेत जा, रेमेडियल करा, शॅडो टीचर ठेवा, बोलायला शिकवा, चाललंय. 8-10 वर्ष निघून गेली. शेवटी नंतर ते लक्षात येतं. Of course, thorough CNS examination for every child. Investigations for all children with suspected problem. Do a CBC and thyroid function, because this is something that you have to know for all child. But if indicated there are specific dysmorphic features or family history, 3-generation pedigree chart, you look at it. Then you do a genetic evaluation. If they're looking to have a next baby, you need to do a genetic evaluation. EEG, if there are frank seizures or sudden change of behaviors or staring spells. MRI brain, if there are neurocutaneous markers or focal neurological deficit or seizures. Male child, never forget to do CPK, because Dr. Rashid Merchant, our teacher, comes to our center now and he has picked up 4 children with autism whom we were treating, and he detected that they also had a concurrent DMD. Fragile X, of course, the commonest known diagnosis in a male child with autism and subnormal intellectual functioning. And if it is a female child, especially with a history of regression, definitely do a MECP2. Evaluations that a pediatrician, all pediatricians should do and can do is MCHAT, but don't forget to have a detailed vision and a hearing evaluation. When you refer it to one of us, we will do a detailed evaluation battery. But what is important is the clinical impression at the end of the day. Very important role for general pediatricians or regular pediatric practices. Look at the comorbidities. Don't bother so much about the hyperactivity, intellectual disability. Leave that to us. But bother about malnutrition. Many of these children have overnutrition or undernutrition. Dental problems are very common. They may have constipation because of poor training, and they may have sleep disturbances also because of poor training. Of course, there could be intellectual disability, ADHD, aggression, OCD, anxiety, depression. Leave the right-sided stuff to the developmental pediatricians. But the left stuff, there is no reason to think that a child with autism cannot have a dental abscess or cannot have pharyngitis or tonsillitis or appendicitis. That's very important to keep dealing with that. There is a role for medications only for comorbidities. We use methylphenidate and atomoxetine very commonly for ADHD. For risperidone, I use risperidone for aggressive behavior. For anxiety and depression, we use fluoxetine. Melatonin can be prescribed for sleep disturbances, and constipation, of course, you all know better than all of us what to do. Very important, it is not a speech disorder, so don't tackle speech at all. First, tackle the other parts. Not a learning disability, so don't start with reading and writing. It is not due to father speaking late, not due to multiple languages at home, not due to lack of exposure, not due to excessive screen exposure. So these things are very important. Finally, to close with last 2 minutes, at New Horizons, we have come up with a new theory for autism, which is called the theory of social interaction, where we believe this is not a separate speech problem or behavioral problem or sensory problem. We don't believe that. We believe there is a social communication sequence, and the normal development of a child goes along this sequence. But if the first part of the sequence is altered, the child will not learn the further parts or will not master the further parts in the sequence. The other thing we believe is we don't call this swamagnata. At New Horizons, we call this ati vastu magnata ani kami manushya magnata. So we need to shift the child from objects and patterns and screens towards meaningful human social engagement, which was similar to what Lev Vygotsky spoke about in his theory of zone of proximal development. Communication, as we always say, needs to be IMP, interactive, meaningful, purposeful. So at New Horizons, we have used this theory to come up with a model which is developmental pediatrician led and parent mediated intervention, which requires very little therapies and a very small role of therapies and therapists are required. And we can do this both center based as well as online. So the program is called New Horizons Development Program, which focuses on the basics of normal development. And there is a paradigm shift in our program from symptom therapy or therapy based approach to a targeted sequence oriented interventions, which covers the entire sequence of problems based on the theory. This standardized in a scalable model, which again is led by developmental pediatricians and monitored by developmental pediatricians along with the general pediatricians. So these are just some cases. Now, this is the history of our child. This is our online program where we don't even intervene directly with the child. We only coach the parents on an online program. So when they come with a history like this, there is a software which we have developed in which we arrange the child's concerns, and even 2 to 3 months later, working on an online coaching of the parents, there is an improvement in all these things. I won't go into detail because we are running out of time. But just to show you that with the right approach, with the right concepts, even online, we have children now. This lady in the middle, Miss Yogita, is a parent from UK. There is one person from other cities of Maharashtra. So these are all the children, parents whose children have showed improvement. Key messages: arbitrary referrals, arbitrary consults, therapies, as hey kara, udya te kara, they don't help. Sometimes the child may seem to be doing better, but that's not the truth. Hence, the pediatrician has to follow. Remember, individual therapies or department-wise or specialty-wise referrals will not help. It is an overall program to be made by the development pediatrician and the family pediatrician. And there are no fixed programs. All programs are dynamic. I see children 6 महिने चालले थेरपी, 1 वर्ष चालले, 3 वर्ष थेरपी घेतोय. काय करताय त्याच ऍक्टिव्हिटीज. तरी प्रोग्राम्स आर डायनामिक. 3 महिने जर प्रोग्राम केल्यावर मुलात इम्प्रुव्हमेंट होणारच. इम्प्रुव्हमेंट झाल्यानंतर पुढची स्टेप्स चेंज करायला पाहिजे. नाही तर मूल तिकडेच राहणार. Inclusion begins not in the child development center or the school, but begins at home in the neighborhoods, and hence involve the families and parents. Understand the parent situation may be far different from what you think. बऱ्याच वेळा आपल्याला म्हणतात अरे बिचारे पालक काय करतील, कशाला त्यांना एवढी मेहनत, का त्यांचं आयुष्य बिघडवायचं, आपण कोण ठरवणार? त्याला करायचं असेल मुलाची मेहनत तो करेल ना. आपण का असं एकदम ओव्हरऑल पेट्रोनायझिंग अप्रोच घ्यायचा, नको नको तुम्ही ना फक्त 3-4 वेळा ओटी करा, तुम्हाला जमणार नाही, तुम्ही स्पीच थेरपी करा, तुम्हाला अरे त्यांना स्पष्ट सांगितलं पाहिजे काय करायला पाहिजे. त्यांची जर तयारी असेल आणि ते करत असले तर मुलं नॉर्मल होऊ शकतात. कारण वी रिक्वायर अ विलेज टू मेक द चाइल्ड टू लर्न. And hence the big role is of developmental pediatricians and all pediatricians and not just therapy teams. So these are Dr. Barkha is my colleague, Dr. Hila is with us, Dr. Aradhana Sukarwala. So very important, we are now making a call for pediatricians to learn more of developmental pediatrics and look after children on their own rather than just referring or outsourcing children. So these are our wonderful teams of therapists, occupational therapists, speech therapists, psychologists, special educator, physiotherapists, but along with Dr. Rashid Merchant, along with the developmental pediatricians, because it's very important to have a developmental pediatrician-led program which can be monitored. Acknowledgements to IAP, Maharashtra IAP, Indian Academy of Pediatrics, chapter on neurodevelopmental pediatrics, and finally our team, because whatever I have shared is something which I have learned only from my team and not from the CDC, United States of America. And finally, this is a book brought out by Lina, myself, and all our other colleagues, which is easily available, and all of you can read it in simple language. It has been written. IAP's first handbook on developmental behavioral pediatrics. Thank you very much for a very patient and supportive participating experience. So thank you very much. And if there are any questions, I'm sure Lina and I will be happy to take them.
Thank you so much, sir, for your wonderful presentation, and we had learned many more from this presentation. And the most important point we learned was the hearing and vision testing is most important part, along with the developmental history and developmental milestones, as well as we came to know about the red flags you had told about the autism for the diagnosis. Sir, there is one question from chat box which I would like to ask. If ASD missed in childhood, what can be the problem faced as adolescent individual or as an adult?
It's a very good question. That's exactly the 7th case which we discussed. The problem is behavior in society, interactions with people. कुठे कसं वागायचं. Unfortunately, आपण फोकस करतो कुठे म्हणजे बोलायचं. बोलणं हा इम्पॉर्टंट नाहीये. कुठे कसं वागायचं, कुठे कसं वागायचं नाही. कुठे कसं बोलायचं, कुठे काय बोलायचं नाही. हे कळलं पाहिजे. And if we don't do the right sequence-based approach, if we directly jump to only training for speech and reading and writing, this problem remains behind in adolescence. So the parents of a child with adolescence will tell you, जाऊ दे reading writing करत नाही, हरकत नाही. पण तो घरी माणसं आली ना आमच्याकडे नातेवाईक किंवा कोण आलं दारात तर तो कपडे काढतो, पॅन्ट काढतो किंवा त्या बाईला इनअप्रोप्रिएटली टच करतो. कुठल्या मुलीशी कसं वागायचं त्याला कळत नाही. किंवा मुलगी असेल तर ती कोणाला जाऊन मिठी मारते, तिला हे कळत नाही की ह्यांच्याकडे जाऊ नये. These are the complaints of parents of adolescents. And this happens in spite of a diagnosis at 3-4 years. The early intervention, worst term hai. Worst term hai early intervention. Right term should be correct intervention. Appropriate intervention. Early intervention चा एक मार्केट झालेलं आहे. त्या लेबल खाली लोकांनी दुकानं उघडलेली आहेत की अर्ली इंटरव्हेन्शन मी देतो म्हणे. अरे काय अर्ली इंटरव्हेन्शन काय देता काय तुम्ही? अर्ली असेल पण बरोबर असलं पाहिजे ना. अर्ली चुकीचं देऊन जास्त वाट लागते. अर्ली इंटरव्हेन्शन हे ब्लँकेट टर्म सोडून द्या. रिफर टू एक्स, रिफर टू वाय हे सोडून द्या. मुलाचा प्रोग्राम काय असला पाहिजे, मुलाचे प्रॉब्लेम्स आता काय आहेत ते टॅकल काय व्हायला पाहिजे तिकडे लक्ष दिलं पाहिजे.
Okay, sir. Thank you. My next question for Lina madam. There is a question in chat box, ma'am. What is the long-term prognosis if intervention started early?
So I think Dr. Sameer has just highlighted that having appropriate goals or developmentally appropriate goals is very important and is probably the mainstay of treatment than having just an intervention. Prognosis would depend on a lot of factors: the cognition of the child, the behavior of the child, how the child is coping up, and how, the support that he gets from family and, the extended family. So I think we can't probably put it as a one shoe fits all kind of a prognosis. It may differ. The one side of the story, I think Dr. Sameer has highlighted very appropriately, that the ones who are less verbal or probably cognitively and fairly okay, but they are socially not able to cope or not able to, they're not being taught socially appropriate behavior, so to speak, maybe misunderstood in adolescent, and the parents may have a really tough time. We also see the other end of the spectrum where they may be cognitively better, they may be verbose, they may be, quite okay, and those are the milder symptoms, but even they may have a lot of problem. I think the best of us have problems in adolescence. So imagine a child jala, he's socially naive, he's not very chanta as we call it, So एक जो चंटपणा येतो adolescence मध्ये तो जर नसेल, he gets bullied, he, it creates anxiety for him. थोडा डिप्रेशन यायचे चान्सेस पण असतात, कारण ऑब्व्हियसली ही इज नॉट एबल टू कोप विथ हिज पियर्स, आणि मग चिडवणं आणि बुलिंग कम्स व्हेरी इझिली. सो आय थिंक इट इज इंडिव्हिज्युअल, बट देन इट कॅन बी एनी एंड ऑफ द स्पेक्ट्रम, अँड आय होप with better goals and better appropriate interventions, we can give them even better, futures. But I think a lot of change, not only from us as pediatricians, but from a society as whole. And I think that goes with our theme for this year, inclusion in society, or inclusion at workplaces or schools, because I think that is one place where we have a long way to go. कारण अजून चिडवणं, families don't take these children out. Just like Dr. Samir said, काकाकडे जायचं सोडून द्या, कुठेच जात नाही ते बाहेर घेऊन. I mean, imagine you have a child who has a problem in social life and you are excluding him from social life. When and how is he going to learn? I think हे आपण सगळ्यांनी स्वतःलाच विचारायला पाहिजे. We have children celebrating their birthdays also with us at hospitals, कारण मुलं येत नाहीत आमच्या birthday parties ला, आम्ही जाऊ शकत नाही birthday parties ला. So I think prognosis depends on a lot of factors. One, which probably we can create an awareness for today, is amongst ourselves as healthcare workers and society by your other workshops for parents and teachers.
Thank you, madam. One more question for Samir sir. Sir, our theme of this year's autism is inclusion in workplace. Sir, I would like to ask what workplaces will you advise, or is the theme related to more to the adult autism, or means is it applied to child also?
मुलाची वर्कप्लेस म्हणजे प्लेग्राऊंड, शाळा. पण तिकडे पोहोचायच्या अगोदर आपला जन्म होतो घरात. घरात जन्म झाल्यावर दुसऱ्या दिवशी आपण मुहल्ल्याच्या मुलांबरोबर खेळायला शिकत नाही. पहिले वर्षभर आई वडिलांकडे, मग काका काकी, मामा मामी, मग शेजार, मग इतर अनोळखी माणसं, मग शाळा, मग कॉलेज, आणि मग वर्कप्लेस. तर थीम जे असतात युनिसेफचे वगैरे वगैरे, बऱ्याच वेळा ते फक्त एक म्हणजे त्या थीमचा आवाज गेला पाहिजे असं असतं बऱ्याच वेळा. आणि बऱ्याच वेळा त्या थीम मध्ये फक्त आपण डायरेक्टली पुढे जम्प करत असतो, पाठची जागा भरत नसतो. डायरेक्ट बिल्डिंगचा ग्राउंड फ्लोअर नाही, फर्स्ट फ्लोअर नाही, सेकंड फ्लोअर नाही, 10व्या माळ्यावर इंटिरियर करायला जास्त मला फेवरेबल वाटत नाही. तेव्हा जर वर्कप्लेस मध्ये इन्क्लुजन करायचं असेल तर आधी तुमच्या घरात सुरू करा, घरानंतर नातेवाईकांच्या घरात इन्क्लूड करायला घ्या, शेजारात इन्क्लूड करा, आणि शेजारानंतर शाळेत होईल, आणि त्याच्यानंतर मग वर्कप्लेस मध्ये वगैरे होईल. मी सकाळमध्ये एक आर्टिकल लिहित असतो शनिवारी, बरेच आपण लोक त्याचं दाद पण देतात. गेल्या वेळी जो आर्टिकल लिहिलाय तो शेजार धर्मावर लिहिलाय. धर्म म्हणून खरा तो धर्म खरा आहे, कारण शेजारात जे मूल शिकतं, आणि हे मी म्हणत नाहीये, हे लेव वायगॉट्स्की म्हणतो, त्याला आपण स्कॅफोल्डिंग म्हणतो. तो 100 वर्षापूर्वी हा रशियन सायकोलॉजिस्ट 39 वर्षाच्या वयात गेला तो, पण त्याने 39 वर्षात जेवढं सायकोलॉजीचं काम केलंय कोणीच केलं नाहीये. स्कॅफोल्डिंग म्हणजे एखादी कुंपण धरून ती वेल जी असते त्या कुंपणीच्या त्याला धरून वाढत असते, त्याला स्कॅफोल्डिंग म्हणतात. आणि समाजात जन्म आलेलं मूल आई वडिलांना धरत धरत, आजी आजोबांना पकडत पकडत, काका मामा, नंतर शेजारचे काका काकी मावशी, शेजारची मुलं धरत धरत तो शाळेपर्यंत पोहोचतो. ही एक नवीन टर्म डिफाईन केलंय, फ्रॉम क्रेडल टू क्लासरूम. आणि त्या क्रेडल टू क्लासरूम मध्ये एक खूप मोठा डॅमेज आहे किंवा एक एक्सटिंक्ट झालेला आहे, ते म्हणजे शेजार. तेव्हा इन्क्लुजन युनिसेफला जे अमेरिकेला करायचं ते करू द्या, आपण भारतात महाराष्ट्रात इन्क्लुजन इन शेजार हे आपण मेसेज दिला तरी मला आनंद होईल.
अच्छा सर, थँक्यू सर, थँक्यू व्हेरी मच. एनी मोर क्वेश्चन्स? Someone would like to ask any question to Samir sir or Leena madam? As we have next session also at 4 p.m. Then I would like to invite our Honorable Secretary for his vote of thanks. Dr. Amol Pawar sir, over to you.
Thank you, Sonali madam. Thank you, my elder brother, Dr. Samir Dalwai sir, Encyclopedia of Developmental and Behavioral Pediatrics, for summarizing various aspects of autism in relatively short articles through various cases, as well as providing basic overviews of all topics and answer to simple facts. Thank you, respected Dr. Leena Srivastava, Madam, who was present in this session as a guest of honor. I congratulate Dr. Renu Ma'am and Dr. Sonali Ma'am, backbone of Maha-AP Women's Committee, for conducting various sessions for pediatricians, parents, students, and teachers also. I thank all attendees on Zoom and YouTube who were present throughout the session on behalf of Maha-AP. We will be conducting many more sessions in near future. Thank you one and all.
Thank you, sir. Thank you very much. Thank you all, audience, faculty, speakers. Thank you very much.
Thank you to Maharashtra IP and the chapter on and the women's entire group who has been working so well. Thank you, Hemant Bhai, Amol ji. Thank you, Sonali. Thank you,
Thank you,
Leena,
sir. Thank you.
and Renu and Jaya Madam and Sonali, who have taken so much effort. Kashmiri, thank you so much.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you.
Thank
It
you,
was a
sir.
very, very nice